what type of benefits do the PCSK9 inhibitors offer on top of what a statin typically does? Not in one-off case.
Aside from LDL, the biggest is reduction in MI and stroke, and the reduction in events.
And what about the side effect profile?
Well, I mean, I think from an efficacy standpoint, it's just what you said. Those patients that have ASCVD that are uncontrolled, it gives us that added benefit of being able to reduce that LDL further. It gives us an option for that patient that truly can't tolerate a statin to lower their LDL. So I think the efficacy of lowering the LDL is a benefit in the right patient, not for everyone. From a side effect profile, I think they're well taught. I think there's just tolerability issues around injection site reactions. From a safety standpoint, they appear to be safe. You know, we have data now that shows that they're used with us.
I mean, but that's interesting. Both those comments lead me into an important point. You mentioned also earlier the rate of denials. So the biggest challenge for us is most of our requests for these drugs are in patients who are not on a statin. And I think that makes sense. If you've had rhabdo or something, or you can't take a statin, then you need another alternative. I get that. But I think 99% of the patients in the trials were on a statin. And so all we're asking is that a member stays on a statin. So whether you're moving from a high potency to some other statin, at least we want them on a statin, because we don't know. We understand intuitively that we're going to see a significant LDL reduction with these drugs. That's proven, right? But we don't know outcomes. We don't know if there's going to be a reduction in events if you're using this without a statin.
It is worth noting that some of the effective statins, right, are not just on LDLs.
Right.
The statins actually improve compliance, and they decrease inflammatory responses, independent of the LDL cholesterol. So I guess that's what you're getting.
But it kind of ties in who the appropriate patient is, the budget impact, how much we're spending, our willingness to pay, it's evidence-based. And so if that's one question I think that has to be answered, is what is the reduction in events with these drugs not on a statin? Because that's a completely different population.
But the conundrum is getting patients onto a statin. You know, we talked about this in the very beginning, so we kind of come full circle. So that's the conundrum is, I think, we need to treat patients with high-intensity statins first. It's just getting those patients on it.
Now, if a patient isn't on a statin, I just want to be very clear. If a patient's not on a statin because of statin intolerance, that's not the same. You're not talking about that, right?
If it's true statin intolerance, we're not, there will, more than likely, these drugs will be approved.
All right.
It's the not clear statin intolerance and the fact that they haven't tried a statin in 5 years or 10 years or whatever else is going on, and we see a lot of it.
All right. Now, you were worried about CNS effects. People are worried about brain effects because part of what's going on in the myelination process in the brain depends on cholesterol, and the concern was what? LDL cholesterols of 30 may impair cerebral function. Mm-hmm. Was that a red herring, not happening, or what?
Well, I mean, it didn't happen in the 2-year study. Now, there's an extension going on with that study to see if there's any long-term effects on it, so we'll study it a little bit longer to see. So I think that question still has to be answered. I think there's still a population of providers that are still concerned about that particular side effect, but at least in that 2-year study, we haven't seen it. We haven't seen it in either one of the drugs.
It's worth noting also that statins do have CNS side effects.
They do.
A fair number of folks, in addition to the rhabdo and the muscle pain and whatever, renal failure, a fair number of folks discuss more subtle CNS changes, word finding, for example, right?
And those are considered to be reversible when the drug is stopped. So I think what we'd be more concerned about is something a little more permanent if we're looking at long-term effects of having low LDL, which, as Bryan mentioned, we haven't seen yet. Even in older studies where they've looked at LDL levels less than 40, we haven't seen that. So that'd be the major concern.
Do these drugs cross the blood-brain barrier? Does anybody know?
My guess is going to be no due to the size of monoclonal antibodies, but I guess I don't know the answer for sure.
But again, the statins apparently do, whereas these may not, and maybe that accounts for some of the...
Yeah. And I don't think we're concerned about the drug itself causing neurocognitive defects. It's the profound LDL lowering that causing it.
So the safety profile here is rational on these new drugs. So let's take a look at some of the research. You've been talking about it. There was the New England Journal article about this at Fourier, is that right? What do these outcome research studies with PCSK9 inhibition really show? Let's put it all together into a great big meatball, and tell me what this is all about. What is the research supporting here?
A significant reduction in LDL and a reduction in stroke and MI on top of a statin. So good data.
With data.
With patients with an LDL already at goal.
Yes.
Because the average LDL starting in that study was 92.
92.
Ah,
Yeah.
no, that's
Good
something we didn't
LDL.
hear before. That's important, right? And that's what you were alluding to, patients already on statin therapy, and we presume they're on statin therapy because their LDLs were high. So if you see 90, somebody a priori walked into your office with an LDL of 90, you wouldn't a priori necessarily go ahead and give them a statin. So these are folks where you've been driving the statin down already. And then as I understand it, on top of that, you're telling me, they gave the new drugs and drove it down further, and they had a decrease in
Well,
stroke.
and that's the issue is we know we're going to get an LDL reduction with these drugs. We don't know if we're going to get a reduction in events without the statin.
Okay, that study's yet to be done? Or is anybody willing to do that? Is that an ethical
I
study?
think they're
to do?
looking at patients with not on statins.
Okay, and
both
presumably that would be
manufacturers, but-
patients who couldn't tolerate
Yeah,
statins to start
and
with.
that changes the criteria. But the other I just want to get back to that though. If these drugs were priced like a branded statin or something different, then we would not be doing this. So it's the cost of the medication that is requiring us to manage the way we are. And the other downstream impact of that is because of the trends that I mentioned earlier, with these escalating costs and specialty drugs and budget impact to employers, and really, not having money to pay for medications potentially moving forward, is that some of the few mechanisms we have in place to manage that affect the member. So it's more use of closed formularies, more co-insurance, higher deductibles. And so that's another barrier with these drugs. And even if a patient is appropriate for these drugs, now we have other factors that we have to take into play to make sure that they're compliant on these drugs. We've talked about compliance with the other drugs, but now you talk about a high out-of-pocket and an injection and a number of other things once we identify the patient, we have to do a lot of work to make sure that these patients are staying on these drugs.
But I heard something buried in that answer that I want to ask everybody else about. You said, tell me if I misunderstood your answer, if these drugs were priced the way branded statins are priced, we wouldn't be having this conversation. And the conversation is entirely about on-label use in compliance with research. Did you mean to imply that if this drug was cheaper, you would approve it more for off-label use or not in compliance with this research?
I do, because we would probably not be using prior authorizations the same way we are now.
There you go. So that's what happened with statins, right? And docs started prescribing them because they worked, even though the research took a while to catch up. Should price be the driver on that?
Cost, efficacy, and value should be the driver.
Yeah.
Go ahead, beat them up. That's what we're here for.
Yeah,
I mean, I was
That's a little
leading him
tough.
into a cul-de-sac.
exactly.
Or maybe he
And I
stepped there
think-
himself.
I think one of the tough things also that Jeff mentioned was passing the cost on to the patient, right?
Okay.
There's a higher out-of-pocket cost
Challenge.
to patients for higher cost therapies, and it's a challenge for patients. And we talked about what are the why are patients not seeking treatment? I mean, there's abandonment on prescriptions, particularly in patients who these patients are comorbid, so they probably have 3 to 5 other prescriptions that they're taking.
Yeah.
So
But these are expensive drugs. On the other hand, what we as the medical community, and I include payers with that, as the statins came down in price, we recognized that a lot more people could benefit from them that was indicated in the original literature, so we just expanded it, right? At first, statins were what? Just for high-risk patients who were diabetic, hypertensive smokers. And now everybody gets them, as long as their cholesterols are too high. So is it just the money that's driving this, really? I mean, and is that right?
Well, I think if data
go ahead.
continues to prove that cardiovascular risk reduction if we can say, the problem we got in medicine a lot is a silo effect. So the costs associated with drug costs is in one silo, the overall healthcare costs is in another silo, and they often don't communicate. And in a lot of situations, there's data out there to prove that if you perhaps spend more money on medications, you can save more money to the
Yeah, we're
overall
gonna get
healthcare
to that,
system
too.
by rationally managing those medications. So I think it comes down to just choosing that right patient and rationally managing that medication to be appropriate. I mean, you just can't open the door and say, okay, everybody gets
It's the appropriate patient, but I also think it's completely unfair to say we just focus on clinical and ignore cost. Both of those have to be addressed